Hey guys, Woodruff here. So we're getting through these rhythms. We are actually almost done getting through the rhythms, so yay! I know it seems like they take forever, but hopefully breaking them down one by one is making a little bit more sense. So now we just talked about ventricular tachycardia, which is a bottom of the heart problem, and we know it's a bottom of the heart problem because it's got that fat QRS. And it is, we can't really see anything going on with the P waves because it's just that fat QRS, and that it is fast, fat, and fairly regular. Now let's talk about Vfib. So in VTAC, and I didn't really talk too much about the rhythm itself, but in VTAC, there can be possibility of a pulse. When we're getting to the point where we're in Vfib, think of like AFib, where the top of the heart is fibrillating, but this is now the bottom of the heart. So the top of the heart, we can get away with the top of the heart fibrillating because, it can fibrillate and we can still get some cardiac output out. But if the bottom of the heart is fibrillating, we can get zero cardiac output, zero output out. It sounded weird when I said that. And so we have a very serious life or death problem. So how are we going to identify this rhythm? So we're going to identify in the fact that there's no discernible P waves. So I can't see any P waves. And so you might be like, well, isn't that like a top of the heart problem? But wait, the big thing we always look at is there's these fibrillatory QRS complexes. In other words, like I can't even tell what's going on here. Like, look at this rhythm. Like, what the heck is going on? It's just a bunch of squiggles back and forth. It's irregular, R to R. Like I can't measure. I don't know. Like I can kind of see there's like a distance here, but like what's going on at some of the rest of these, it's really hard to tell like what's going on or what the distance is between some of these. And unlike the other, when I talked about VTAC, it's a lot more predictable. I can count a rate. I can't count a rate here. Like I could try to, but it'd be really difficult to count a rate here. It's just a bunch of squiggly lines. It's not like those distinct V's like you're going to see in VTAC. And this one is a little bit more organized than some. I'll show you on the next slide that usually it is not necessarily as organized as this. So probably the most important thing I could tell you is there will never be a pulse in a patient with Vfib. So compared to VTAC, where they can have a pulse or no pulse, like there's no Vfib with a pulse. If they're bottom of the heart is fibrillating, there is this is an emergency. Like I need to immediately start CPR. I'm going to do the same thing kind of like I did for VTAC without a pulse, where I'm going to start CPR. Then I want to get that defibrillator as soon as possible. And definitely for VTAC without a pulse. But if you've probably heard this Dfib for Vfib, it is so key that you recognize that we want to get that defibrillator as soon as possible. So if I'm sitting there and I'm like, hey, I'm starting compressions, I'm yelling to someone else, grab the crash cart. I want to get this patient attached to the crash cart so that we can get that defibrillator attached and shock them as soon as possible. We're also going to do the medications to restore circulation, which is going to be things like epinephrine, and then convert the rhythm. I talked a little bit about like things like amiodarone and things like that sometimes can be used. It just depends on the rhythm and stuff like that. So sometimes we use those for patients that do have pulses and have things like AFib, but we can also use them for other rhythms as well. So, like I mentioned, Vfib can be fine or coarse. So sometimes it can look like this. So you can see where in this one, I'm like trying to count and I'm like, wait, how many beats is this? Oh, is that 2? Is that 1? Like what's going on? It's really hard. So you can also see it can be coarse, like that last rhythm, or fine. Like here, there's no way that I can tell like what the rate is here. So you can see it's a lot more disorganized. So with VTAC, it was a lot easier to count. I could tell that there were actual like semi QRS complexes, even if they were fat and a little bit irregular. This, I can't count anything. I do not know what's going on. There's nothing I can do. It's just chaotic electrical activity. So to sum up Vfib, no pulse. There is fat QRS, or really a non-discernible rhythm. It looks just like a squiggly line. There is still some electrical activity there. It's not a flat line. There's squiggles there. I can't count the rate, and I need to do emergency treatment, start CPR, Dfib as soon as possible, epinephrine, other meds that might help to convert the patient into a normal rhythm, and use that ACLS protocol. But that's effectively Vfib and what you're going to want to know about it. We will get into asystole next, if I can find my mouse and actually get it over here. Anyway, I'll see you for the next one.